Our next presentation will be on ALD standards of care in pediatric neurology. Please welcome Dr. Eric Mallack from New York Presbyterian and Weill Cornell Medicine.
Can everybody hear me? So it's nice to be here. It's nice to be here in person, and thank you again for inviting me. Excuse me. So I'm going to talk about the imaging standards of care. Many of the people in this room have seen a lot of these slides. I think I'm aiming this talk, of course, always at the new parents and new families who are joining us. So just a couple of my disclosures here about research involvement. And really, I wanted in 30 minutes or less, just have a couple of goals. Really want to illustrate late versus early stage CCALD. Talk through the surveillance recommendations, and I look forward to the questions about how we go about doing MR surveillance. I'm generally the person who represents the group of people who are responsible for the imaging every 6 months. And this last point, I've been thinking a lot about it, understanding timing of lesion evolution in the pre-symptomatic kids. How much time do we really have? So, you can't hear? Let me try this. Is this better? All right. I feel like a comedian. I got to talk right into the microphone. Or like an airplane pilot. All right. So I've learned not to bury the lead too much, and I like doing take-home messages early on. Hopefully it'll frame how we're thinking about this. So childhood cerebral ALD should, of course, be acted upon urgently. If you talk to some of the physicians who are more classically trained prior to newborn screening, childhood cerebral ALD is a neurologic emergency and should be treated as such. But what I want to point out, now that we are looking at patients earlier and earlier, I put this line in here. If a patient is identified with very early disease, a less score of 1-ish, and these definitions of very early disease and early disease, I stole from Dr. Pierpont, early disease being a less score less than 4, and very early disease being a less score less than 2, because as she pointed out in her talk, there are neurocognitive benchmarks that are associated with these cutoffs. What we found is that if a patient is identified with very early disease, a less score of 1-ish, plus or minus 1, or maybe plus or minus a half, and is treated, and I'll explain what I mean by all comers, by 7 months, but certainly within a year, we expect that the less score at treatment should increase about maybe a point, maybe 2. And the expectation in that 7 months to treatment, and I'll show you the data for this, is that the majority of those patients should remain pre-symptomatic, at least neurologically, at treatment. But what this is starting to give us is insight into the arena of how much time we have to actually treat patients. It's probably going to run contrary, which is why I put the first line there, to the classic teaching. And the caveat here is the second a cerebral lesion is identified, people should be moving urgently. But I want to, as DJ pointed out today, put some data to the recommendations. So this is the untreated natural history of childhood cerebral ALD. The top curve is overall survival. The bottom curve is major functional disability-free survival. And as we see, everyone knows in this room, as time goes on, patients unfortunately deteriorate and then eventually succumb to disease. If you treat a patient with advanced CCALD or non-standard, so a less score greater than 10 and essentially symptomatic, the curve on the left will demonstrate that patients survive, that's that top black line, but they'll become progressively more symptomatic post-transplant. If you transplant a patient with a less score less than 9 and really 0 neurologic symptoms, or I guess less than or equal to 1, maybe 1 neurologic symptom, the patients survive and the vast majority will remain free of major functional disabilities. So our goal, of course, is to identify early stage active disease as early as possible prior to symptom onset. And like I said, this work has been out there for a little while now. So what are the the signs of early stage cerebral ALD? So this is classic CALD. Everyone knows this in the room. The left is a T2 flare showing the degree of demyelination, and on the right is a T1 post-contrast image demonstrating the ring of Garland enhancement indicating blood-brain barrier breakdown. So this is work that we published a few years ago now, and instead of those large lesions, we're looking for, let's see if I can get we're looking for these tiny little changes, mostly in the splenium of the corpus callosum and in the genu of corpus callosum. And here it is again. Some of the more challenging lesions to identify sometimes are in internal capsule on the brainstem, where you see it in cross-section here. And we're looking for these blushes, these tiny bits of lesional enhancement, telling us that the disease is active, and that is the reflex signal, at least right now, to go to stem cell transplant or gene therapy. So the question is, how do we monitor for this disease? And so we know patients can now be identified at birth. They're asymptomatic. 30 to 40% of boys develop a lesion, so there's lesion onset, and then there's this lag time between lesion onset and symptom onset. We call that the pre-symptomatic time period, symptomatic. And then going back to those survivor curves, the goal is to treat a patient in that pre-symptomatic time period with stem cell transplant or gene therapy. So how do we do this? We essentially take MRI images every 6 months early in life until we are able to detect lesion onset and then get patients to transplant. So this was a meta-analysis that was published a couple of years ago now with work by Helena Yan, who is now in medical school, and Dr. Bella Turk, looking at about, I think it turned out to be, 1,000 cases. And so if we look at the individual cases pulled from the literature, we ask the question, well, what's the age of childhood cerebral ALD leukodystrophy diagnosis? 90% of the cases fall between 3 and 12 years old. And the median age was 7, so 6.5 to 9. These were mixed asymptomatic kids and kids with early cerebral disease. So we came up with these imaging recommendations, obtaining the first MRI somewhere between 12 and 18 months old, second MRI after baseline, and then really between 3 and 12 years old, we recommend a contrast enhanced MR every 6 months. And I think that's up for discussion about how to do that, and that's a conversation that we can definitely have. One of the major contributions of this work was we recommended not getting an MRI in the first year of life. So prior to this, and prior going back into the literature, the really early recommendations were to start MRI screening within the first year of life, and we've sort of put a nix to that. As it turns out, and I can show you some more data as we go along, again, it's up for discussion about when we start screening and how we do it. The major considerations are, of course, exposure to gadolinium, and then exposure to anesthesia, and the strategy by which you either make use of a patient being anesthetized for an image and doing all the sequences, or do non-contrast imaging. And then if a patient develops a lesion, then you have to anesthetize them again to get the contrast-enhanced scan. So there was a lot in those couple of sentences, but I can definitely explain further in the Q&A portion. So there was an international effort to do this using the Delphi procedure, where physicians and people who are familiar with ALD from around the world voted on recommendations. This was headed up by Mark Engelin, and this is an entire talk unto itself, but I will just orient you to the top row here. The surveillance recommendations that we came up with were to start at 2 years old, and essentially have imaging from 2 to 12 every 6 months. In this paper, the recommendation was to do non-con non-contrast enhanced MR surveillance. But then, of course, with the caveat of, well, if you're going to sedate a patient, should you just do the gadolinium and in the event that a lesion shows up and prevent a second anesthetized MR? And we can talk through the details as to international differences in terms of medical systems and ordering MRIs and how that goes. So the next question we really wanted to ask was, well, all right, well, how long is this? How long is the pre-symptomatic time period? And we're not going to allow a patient to develop a cerebral lesion and then just follow them until they develop symptoms. That's, that's obviously unethical. So you sort of have to work your way backwards, looking at the experiences of multiple centers. So a lot of this data was collated and analyzed by Anna Torrey, who works with the group at the Moser Center. So we essentially broke this question down into 3 questions. We asked, okay, well, what age do boys develop early signs of demyelination on the T2? So what age does CCALD first appear? And then from that point, how long does it take for that lesion to develop blood-brain barrier breakdown, which is then the referral scan to go to stem cell transplant or gene therapy? And then from that point, how long did it take, at least traditionally, the patients to get treated? So question number 1, the age of pre-symptomatic CCALD onset is 6.4 years old. That's the median. And if you compare that with what we found from the literature, which was mixed symptomatic and pre-symptomatic boys, this is 0.6 years earlier, so about a half a year earlier. I'll tell you now, if you limit this data set to the patients who are identified with a less score of 1 or 0.5, then the median age of onset was 5.8 years old, so under 6. So as we look, we're able to find evidence of early cerebral ALD earlier in life, which should then give you more lead time in terms of treatment. So the second question was, okay, for the patients who developed a demyelinating lesion, how long did it take for that lesion to enhance? Half the patients had evidence of lesional enhancement at the time of their diagnosis, and then the other half, the median time to development of blood-brain barrier breakdown is about 6 months. And then if you look at all the cases across the board of all the boys who in our data set were identified pre-symptomatically, and you line them all up from their first enhancing lesion, the median time to treatment was 3.8 months. And we can talk about some of the details thereafter. But I bring up this point just to demonstrate that, at least in our study, down there on the bottom, if you treat a patient from the time they have their first enhancing scan and they have a less score of about 1.5, by the time you treat them 3.8 months later, 4 months later, you can expect their less score to bump by a little bit. But the vast majority, 96% of patients, should remain pre-symptomatic. And this data is a piece of validated data in ALD, which we tend to not have a lot of, given it's a rare disease. So unbeknownst to me, and completely in parallel, Dr. Bonkowski from Utah was performing essentially, the same study using the FIS database, which is a large database of health claims. So he studied the same question. He said, well, from the time patients are diagnosed to the time they're treated, how long does that take? And using separate institutions, a separate scientific method, and a different form of data science, he came up with the same answer. So this is a nice piece of data that if we are able to identify our patients early and on median treat them within about 4 months, outcomes should be good. So this is the impact. I just sort of mentioned this. These are independently validated findings in ALD. There's this idea in stroke medicine of door-to-needle time. From the second a stroke patient shows up at your door to the time that they get TPA, it's essentially a standard that if you're the on-call neuro-resident, you're always trying to beat. This can be construed or used as kind of our door-to-needle time. But it'll also help us think about surveillance guidelines. And I'm gonna talk a little bit about this a little more in my next slide. So, so I alluded to this. The earlier we look, the more we find. And so I mentioned the patients in that study who were identified with a less score of 1 or less, so essentially 1 or 0.5. The median age of diagnosis was 5.8 years old. And all of those patients who were identified with these characteristics were treated in about 4 months, and all of them were asymptomatic at treatment. The last patient was treated at about a year. One thing we did observe is early lesions can have flickering enhancement. So you go and do the scan, you give gadolinium, the lesion lights up, showing that there's blood-brain barrier breakdown. You repeat their scan 3 months later to see if it's progressed, and all the while you're working them up for transplant or gene therapy, and the lesion doesn't enhance anymore. And you do it again 3 months later, and you see this enhancement. So we saw this in a couple of patients, indicating that just as treated lesions will sort of flicker off and as inflammation goes away, it might be the case that for some of these patients, if you look early enough and you follow them early enough, their lesional enhancement will turn on, turn off, turn on, turn off, and then turn on and stay on, which is why we look very closely at these boys over time. So I want to give a real-world example to try to get a feel for this. So this is a kid who was sent to me, and this was what his MRI showed when he was sent to me. He was, at the time, 5 years and 7 months old. He's a newborn screening kid. So he showed up in my office. I could tell he has subtle symptoms. And I look at a scan, and this is what it shows. And in getting his imaging, his previous imaging, I went back and looked. And they called a lot of his early imaging normal. But for the people in this room, the people in this room know that this is not normal. That's early stage cerebral ALD. And this is his scan. He was 2 years, 5 months old at this scan. So the earlier they look, the earlier we find. Are there de novo cases less than the age of 3? The answer is absolutely yes. In my short time in this field, I've seen 2. So to quantify him and put him sort of in context for how much time we have to treat patients, he essentially had untreated lesion progression for 3 years. His LES score went from 1 to 10. So he had a change in LES score of about 3 per year. Dan Les and Ali Fatimi in that group created a regression model back in 2003 looking at how lesions change over time using the LES score. And for colossal lesions, the average is about a change of LES score of 2 per year. So this sort of tracks. And so this is kind of where I wanted to couch it in this statement. If a patient is identified with very early disease, a LES score of 1-ish, and you treat them within the first year, but preferably within the first 4 to 7 months, you can expect that your LES score is going to bump maybe 1 or 2 points by treatment, but you should be well within untreated lesion progression over 3 years. One of the other patients in the data set that became symptomatic was a patient who was identified with a LES score of 2, was lost to follow-up, and came back with a LES score of 12 2 years later. So this is kind of giving us what this pre-symptomatic window really looks like. That is not to say that we should not treat patients as fast as possible, but it helps us understand how fast these things start to take off, especially because now we're almost looking backwards in time. So again, I'm going to come back to here the take-home messages and here, cerebral ALD should be acted upon urgently. It is a neurologic emergency. Here's what the expectation should be. We should really be treating patients within 4 to 7 months, certainly less than a year. This is what I think the expectation is in terms of LES score changing over time. And then I'm speaking to multiple levels in the audience here. But this also has implications for response to treatment. So if you're going to treat a patient with a novel medication, we have to treat them long enough to see if the treatment has an effect. I would contend that it's going to take more than a year to figure out whether or not treating a patient with, like, say, a novel medication in a clinical trial will actually have an effect. You need to see a divergence of that change in LES score of 2 to 3 per year because again, the longer back we look, the more lead time we get. But I would say it'd probably take 18 months to 2 years to actually figure out if preventative treatments really do work. Okay, so I'm going to stop there, and I'm happy to take questions.
Okay, thank you, Dr. Mallack. I guess my question is around the contrast enhanced. That's been definitely a concern of mine, and I'm sure many parents out there doing that routinely. So I had talked quite extensively to our neurologist about this, and if I what I recall him saying was he was happy we had the contrast enhanced for the baseline, but didn't feel like it was as important moving for a subsequent routine scan. So I'd just like you to comment on that in your experience.
Sure. Yeah. So I don't think there's a wrong way to do this or a right way to do this. I do think over the next 3 to 4 years, as we gain more experience, we might need to modify the guidelines as we get a more refined understanding of how lesions change over time, especially early in disease. The question that comes up with my patients, and then living in an American system where you have to get pre-authorization for MRIs and do all of this back and forth, is for the kids that need to be sedated, some parents will say, well, just do the contrast, because in the event, God forbid, you find something, you now have to resedate them because you did a non-contrast scan, and you have to resedate them at a later date. Time is passing, and there is always the insurance piece, where you have to then resedate them and then do the contrast-enhanced imaging. So what you could have done in one scan, now you've separated over time, and you've now had 2 anesthesia exposures. But the other way around is certainly fine, I think, and I think that's what we're finding. And maybe that's the underlying one of the underlying possibilities in when I'm talking about some of this data and how much time we have. The European group thinks that doing non-contrast surveillance is okay, and with the understanding that if they find something, then you sort of have to do that second scan and repeat the anesthesia exposure. So those are the 2 main scenarios. Do I have a right answer? I don't. I think one thing that we've tried is at our institution is doing something called real-time reading. So while the patient's in the scanner, once their T2 gets done, we look at it. If it's negative, we just pull the kid out, and we don't give any contrast. But we prep them for saying that we may have to do this. But not everybody can do that. That's a time-intensive, work-intensive setup. And then doing things like trying to scan kids overnight while they're sleeping, that's a nice strategy to try to think about getting off of having to use sedation to scan kids. The movie goggles are great. The books we put out where the kids can read about what it's like to be in a large donut that makes a lot of noise is great. And then there's a desensitization and learning curve that some of these kids accumulate over time. So it's a tough problem. I don't know that I have the right answer, but I'm trying to lay the groundwork a little bit and maybe say something a little bit against the grain in saying that we may be able to do non-contrast enhanced surveillance because the earlier we look, the more we find. But I know there's going to be a lot of friction in the community about that statement, so that's why I'm sweating a little bit saying it up here. Yeah. But yeah, that's right. Healthy debate. Yeah.
I've just had a question sort of messaged to me by a mom who's watching virtually, and she was asking about, you've got these 2 categories of lesions that you're seeing. There's the ones that present frontally and then the ones that present in the corpus callosum at the back of the brain. But a lot of, at least I've seen it a lot in the groups and from a lot of people, you're seeing these brainstem lesions. And the mom was sort of curious if you had any commentary about that as a category of patient, what you're seeing and what you're looking at in terms of how those patients are faring through treatment and how they respond.
Yeah, that's a very astute question. So I'll say this with probably some degree of certainty, looking back at the literature, how colossal, so corpus callosum, frontal and posterior, are reported versus, like you said, internal capsule and brainstem. The thought is it's 15% or less. I'll say my personal experience is, at least in children, I'm seeing more of it. I don't know what's different. Do I think the incidence of brainstem lesions is higher than what's been previously reported? That's my feeling, because I'm seeing it more. But that's my experience. That if I put it in the aggregate, it may not pan out. But take ALD out of it, having any disease in your brainstem, going into any sort of treatment, which is you need to do, is tough, because in neurology world, brainstem is expensive real estate. There are way too many critical structures in such a small space that any disruption you're probably going to see clinically. The reason why we have this pre-symptomatic window is small lesions in the corpus callosum. The corpus callosum is a massive bridge between your left and right hemisphere. One small, tiny affected area is not going to show itself clinically, like, say, weakness or spasticity or hyperreflexia or trouble walking. But if you have involvement of the brainstem, which classically, unfortunately, in cerebral ALD, is of your corticospinal tract, that's the wiring that goes from your brain to your spinal cord to move your arms and legs. You touch that the wrong way, you're going to see it clinically. So your brain has a lot more tolerance in terms of symptomatic development when you have a colossal lesion versus having a lesion in the brainstem. And we just know in general, patients who have brainstem disease for any disorder, tumors, what have you, neurologically, their outcomes are going to be worse. Katie. Yeah.
So as the non-physician, but I think it's just important to say that I think that theoretically makes sense, but we certainly see a number of boys that have lesions that have started there that are doing very well.
Yeah.
And do look great. And so I think early is early. And I also think some of it might be, when we were looking back at some of the older scans, that some of them maybe started there, but by the time they got called, they had moved up. But we have lots of boys that look very, very good, that have a lesion there. So in the book it should be different, but right. I think what you see in your kid is more important.
Right, and at the end of the day, you're absolutely right, Katie. That's what matters, and thank you for pointing that out. It's how the patient actually looks going in. Sure.
There's just one more question in the chat that I can answer yes or no, but I know you'll be able to expand. So after the age of 12, when it is recommended for MRIs yearly, is this for the rest of their life, or is there a time it isn't needed?
Very good question. So we know generally that after the age of 12, the risk of really progressive inflammatory disease drops for reasons we don't, well, at least I'll say for myself, I don't necessarily completely understand. I think there's no real standard around doing the MRIs per se after the age of 12. There are some kids who, let me go backwards. There are patients who I have who are 19, 20 years old who have AMN, and then I look back at their MRI from when they're 12, and they have evidence of cerebral disease, which has just been stable for the past 8 years or 9 years, and it got missed on. It just didn't get called on the initial scan. So if you don't have a lesion, you can do yearly scans. I don't know what the right answer is, but whatever works out with the family. If your kid makes it out of that risk period, could you space it out? I think it's reasonable. If you have a patient who has a lesion that seems to have self-halted, which is a rare event in childhood but does happen, And like I said, discovering that retrospectively by looking at the scans from the AMN patients. I would follow that pretty closely, like every year, at least for the first couple of years. And then the general recommendation, and this is in Dr. Engelin's paper that I pointed out, the general recommendation is you can essentially stop doing MRI surveillance when the patient becomes medically ineligible for a transplant. So things that may include, they may include non-neurological comorbidities that, you take them to a standard transplant, say they had cancer, the medical oncologist would say no because you have kidney disease or you have liver disease and you just can't handle, the chemotherapy. And then in terms of AMN, at least the thought is loss of independent walking and bowels and bladder symptoms would probably be a contraindication to treating somebody with a stem cell transplant, especially an adult who has adult cerebral ALD, just because the risk of decompensation and infection are too high. So it really, that's not to say, at least in adulthood, we shouldn't transplant patients. We've transplanted adult patients at MSK and Cornell, but it was because functionally they were younger and they looked quite good otherwise. So that's a complicated question, but surveillance generally probably isn't indicated if you're not medically eligible for the actual treatment that it's surveilling for. Okay, I didn't get grilled by any of the senior physicians. Perfect. All right.
Thank you, Dr. Mallack, for that.